Good afternoon. I'm Commander Ibad Khan, and I'm representing the Clinician Outreach and Communication Activity, COCA, with the Emergency Risk Communication Branch at the Centers for Disease Control and Prevention. I would like to welcome you to today's COCA call, Preventing the Spread of Novel or Targeted Multidrug-Resistant Organisms, MDROs, in Nursing Homes through Enhanced Barrier Precautions. You may participate in today's presentation via webinar, or you may download the slides if you are unable to access the webinar. The PowerPoint slides and the webinar link can be found on our COCA webpage at emergency.cdc.gov/COCA. Again, that web address is emergency.cdc.gov/COCA. Free continuing education is offered for this webinar. Instructions on how to earn continuing education will be provided at the end of the call. In compliance with continuing education requirements, CDC, our planners, our presenters, and their spouses partners wish to disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Planners have reviewed content to ensure there is no bias. Content will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC did not accept commercial support for this continuing education activity. After the presentation, there will be a Q&A session. You may submit questions at any time during the presentation through the Zoom webinar system by clicking the Q&A button at the bottom of your screen and then typing your question. Please do not ask a question using the chat button. Questions regarding the webinar should be entered using only the Q&A button. For those who have media questions, please contact CDC Media Relations at 404-639-3286 or send an email to media@cdc.gov. If you are a patient, please refer your questions to your healthcare provider. At the conclusion of today's session, participants will be able to accomplish the following. 1. Describe the burden of multidrug-resistant organisms, MDROs. 2. Describe challenges to prevent MDR-O transmission in nursing homes. 3. Define standard precautions, enhanced barrier precautions, and contact precautions. 4. Identify which residents and activities meet criteria for enhanced barrier precautions. And 5, discuss best practices for implementing enhanced barrier precautions. Now I'd like to welcome our first presenter, Dr. Nimali Stone. Dr. Stone is the team lead for long-term care within CDC's Division of Healthcare Quality Promotion. She's a board-certified infectious disease physician with over 10 years of experience developing surveillance, epidemiologic research, and quality improvement projects to track and prevent infections and antibiotic-resistant pathogens in post-acute and long-term care settings. In her role at CDC, Dr. Stone oversees the development of guidance, educational resources, and implementation tools to support infection prevention and antibiotic stewardship activities in nursing homes. I would also like to extend a warm welcome to our second presenter, Dr. Kara Jacobs-Slifka. Dr. Jacobs is a medical officer with the long-term care team within CDC's Division of Healthcare Quality Promotion. She is a board-certified infectious disease physician who has a research and clinical background in managing infections and antibiotic-resistant pathogens, as well as investigating domestic and international outbreaks of infectious diseases and performing healthcare-associated infection surveillance. In her role at CDC, Dr. Jacobs continues to work to contain and prevent the spread of antibiotic-resistant and emerging pathogens in the post-acute and long-term care settings through the development of guidance and educational resources and the support of state and local health department. I would now like to welcome our first presenter, Dr. Nimali Stone. Dr. Stone, please proceed.
Thank you. Good afternoon, and welcome to all of you who have joined us. As you've heard, during this call, we're going to talk about the growing problem of multidrug-resistant organisms in nursing homes and focus on the challenges stopping the spread of novel and targeted MDROs that have been identified during public health responses in this setting. We'll discuss the different levels of precautions used to disrupt MDR-O transmission and introduce a new approach for nursing homes called Enhanced Barrier Precautions. The issue of antibiotic resistance in healthcare is not a new challenge. The CDC Antibiotic Resistance Threats Report, released in 2013, has been raising awareness to the significant burden of resistant organisms, causing more than 2 million infections and over 20,000 deaths in hospitals each year. In your own clinical experience, you've probably observed that infections from these pathogens are often more severe, difficult, and costly to treat. Since this report, we have only continued to identify novel and emerging resistant organisms through the expansion of our laboratory and public health capacity to detect them. On this slide are just a few of the pathogens highlighted in the antibiotic resistance threat report. Methicillin-resistant Staphylococcus aureus, or MRSA, is frequently encountered in nursing homes as a cause of infection and a colonizing organism. Similarly, the extended spectrum beta-lactamase-producing Enterobacteriaceae, or ESBLs, drive cephalosporin resistance in many of the common gram-negative bacteria, such as E. coli and Klebsiella, that can be seen in urinary tracts. Carbapenem resistance in Enterobacteriaceae had been less commonly identified in centers. However, we are starting to find this resistance emerging in the nursing home settings as well as other healthcare centers. A specific type of carbapenem resistance of particular concern has been the rise of carbapenemase-producing organisms. These bugs produce enzymes that can destroy the carbapenems and tend to carry resistance to many other classes of antibiotics. The genes causing this resistance travel on mobile genetic elements called plasmids that can be easily spread to other bacteria. When they cause invasive infections, the mortality rates can be quite high, up to 50%, due to the limited antibiotic treatment options available. And we are detecting carbapenemase-producing organisms in healthcare facilities across the United States. Listed on this slide for your information are examples of the different carbapenemase-producing genes that result in high-level resistance. CDC tracks carbapenemases by these genetic mechanisms. These genes have been reported in a wide variety of Enterobacteriaceae, as well as in Pseudomonas aeruginosa and Acinetobacter baumannii. While commercial laboratories providing services to nursing homes will be reporting carbapenem resistance or non-susceptibility, they may not have the ability to determine whether a carbapenemase is the underlying cause of that resistance. And that is where public health laboratories can offer additional testing to detect those carbapenemases and support facilities when they may be seeing new carbapenem resistance occur in their patients. Another important public health threat to mention is Candida auris. This emerging fungal pathogen has been getting a lot of attention because of its potential to develop drug resistance, its ability to cause serious invasive infections, and the rapid way that this yeast has been shown to spread in healthcare facilities. We will look at a facility's experience with Candida auris during an outbreak in a few minutes. But first, let's look at what we know about the current state of MDROs in nursing homes. This recently published experience involving 18 nursing homes shows a snapshot of MDR-O prevalence on a single day. This group conducted surveillance screening by culturing different body sites from a random sample of 50 residents across skilled, long-stay, and ventilator units in each facility. In the 14 centers with skilled and long-stay units, the median prevalence of any MDR-O being detected was 58%. However, in the 4 nursing homes with specialized ventilator care units, the median prevalence rose to nearly 80%. The most commonly identified MDR-O was MRSA, ranging in colonization prevalence from 25 to upwards of 60% colonizing residents tested in a facility, followed by ESBLs at around 25%. While CRE colonization was rare, less than 1% in the 14 nursing homes providing only skilled care, the median CRE prevalence was 10% in the facilities with ventilator units. So it asks the question, what is driving this high burden of MDROs in nursing homes? As hospitals are becoming the main source of admissions, there's been a steady increase in the acuity and medical complexity of care delivered in this setting. Residents today have multiple risk factors, such as indwelling medical devices, wound care, recent antibiotic use, and hospitalizations, coupled with frailty, comorbidity, and functional dependence, all of which have been shown to be associated with MDR-O colonization or the risk for acquisition. In addition, the frequent patient transfers among acute care and post-acute care facilities, specifically long-term acute care hospitals and nursing homes, has been demonstrated in several studies to facilitate the spread of MDROs within a region. As shown in this figure, which tracks CRE cases moving throughout a network of interconnected facilities. The amplification of resistant organisms has been greatest in centers that serve a high acuity population with long lengths of stay in an environment with limited staffing or challenges with implementation of infection prevention practices. If we go back to the findings from the MDR-O prevalence project for a moment, we see another challenge revealed. Once the team had identified the colonized residents in each facility, they went back to review medical records to determine how many of those individuals had already been known to be colonized with an MDR-O by the facility. Overall, in the traditional skilled centers, only a median of 17% of the MDR-O colonized individuals had any documentation of the organisms that they were carrying. And even in the centers caring for a higher risk ventilator-dependent population, the median percent documented with an MDR-O was still only 20%. So the actual prevalence of MDR-O colonization is anywhere from 3 to 4 times higher than what is documented in the records. So this burden is not only high, but goes unrecognized in a lot of places. And there are many reasons why nursing homes might be unaware of the true prevalence of MDR-O colonization in the residents that they care for. Most centers rely on clinical cultures to reveal the presence of pathogens. And as illustrated by this iceberg, those infections only represent an exceedingly small proportion of carriers. Most facilities do not have the capacity to perform surveillance screening to detect that asymptomatic carrier reservoir, despite the fact that these individuals can contribute significantly to the spread of MDROs within a facility. And it's demonstrated by the findings of that medical record review. Information about MDRO history or risk factors for MDRO colonization are often inadequately communicated during transitions of care. Given the difficulties with managing MDROs, you can see why the novel organisms, with their capacity to share resistant elements, avoid detection, and spread readily within and across facilities, pose such a threat. And it's these characteristics that are the reason why CDC and public health programs are targeting them for containment responses. The CDC containment strategy was launched in 2017 and is a systematic approach led by public health to slow the spread of emerging antibiotic resistance. Containment responses have 3 main components: detection, which triggers a public health investigation in response to the identification of even a single case; infection control, including on-site assessments conducted by the health department for any facility that is cared for a colonized or infected patient; and contact screening, which is provided through the antibiotic resistance laboratory network and offered to the healthcare contacts of any colonized cases, such as roommates or other patients or residents on a unit or floor where those patients received care. And this is done to detect the silent spread that might have occurred. When transmission is identified, ongoing infection control assessments and screening continue to occur until that transmission has been shown to stop or substantially slow. In the first 2 years of the AR containment strategy, we reviewed over 100 CDC-supported responses and found that over 60% involved post-acute care facilities, such as long-term acute care hospitals, nursing homes, and inpatient rehabilitation facilities. 70% of those post-acute care facilities provided some type of specialized ventilatory support. And while ventilator services are relatively infrequent in nursing homes, available in less than 5% of the 15,600 centers in the United States, at least, if not more than a quarter of the AR containment responses have involved nursing homes with ventilator units, really highlighting the increased vulnerability of patients needing this level of care. To illustrate, let's look at how a Candida auris outbreak unfolded in a ventilator unit of a nursing home. This unit had 30 rooms with a mix of double, triple, and even a few 4-person rooms. The response began in March of 2017 with the screening of 65 residents for Candida auris in response to identifying a known case that had come into the facility. And as you can see by this floor map, initially no additional cases were detected. But by about 10 months later, as a result of both importation and transmission on the unit, the prevalence of Candida auris had reached just over 40%. To add an additional level of complexity to the situation, it was found that 2/3 of the Candida auris colonized residents were co-colonized with one or more carbapenemase-producing organism, or CPO. The array of different combinations of resistant pathogens created additional challenges with efforts to house roommates together or cohort individuals on the unit in a way that could slow the spread. As shown on this slide, roughly 18 months from the detection of that first Candida auris case, the prevalence now on this unit had increased to 70%, along with the 60% CPO prevalence. Consistently, the same challenges in basic infection prevention and control practices have been described across numerous nursing homes involved in AR containment responses. These include gaps in hand hygiene adherence, often due to a lack of access to alcohol-based hand rub dispensers, or a lack of knowledge that alcohol-based hand rub is preferred for most hand hygiene opportunities at the bedside. Minimal use of contact precautions and limited access to personal protective equipment, like gowns, challenges with cleaning and disinfection of both environmental surfaces and shared resident care equipment, and poor communication during interfacility transfers. And unfortunately, delays and problems addressing these gaps can result in the amplification of resistant pathogens within this population. The containment experience really demonstrates that preventing the spread of MDROs requires attention to a whole portfolio of practices. And as I hand over this presentation to my colleague, Dr. Jacobs, to dive deeper into the role of personal protective equipment and precautions, this slide is a reminder that gown and glove use is just one of many prevention strategies that are needed to successfully halt transmission. Dr. Jacobs.
Thank you, Dr. Stone. Focusing on personal protective equipment, or PPE, and our previously existing precautions, one common observation that we have made in nursing homes across the country has been that standard and transmission-based precautions are not consistently applied, and inadequate access to PPE can directly contribute to this. I want you to think about standard precautions and transmission-based precautions as being on a spectrum, with standard precautions requiring that a decision is made before providing care regarding the necessary PPE to use for any potential exposure, while transmission-based precautions, on the other side, dictates the use of specific PPE and other restrictions based on a known or suspected pathogen. Standard precautions is a group of infection prevention activities that apply to the care of all patients in all healthcare settings, regardless of suspected or confirmed infection or colonization status. And they're based on the principle that all blood, body fluids, secretions, and excretions may contain transmissible infectious agents. Standard precautions include PPE use, selected based on anticipated exposures, hand hygiene, which is the primary means of preventing the spread of infectious pathogens, injection and medication safety, respiratory hygiene and cough etiquette, which may involve the use of PPE, such as masks, environmental cleaning and disinfection, and reprocessing of reusable medical equipment. Transmission-based precautions are used when standard precautions alone does not interrupt the transmission of an infectious pathogen. The PPE and precautions are based on the method of transmission of a known or suspected pathogen. Contact precautions is used to prevent the spread of pathogens directly from person to person or indirectly through an intermediate object or person. Droplet precautions prevent the spread of large respiratory droplets over short distances, and airborne precautions are designed to prevent the spread of small particles that may remain infectious over time and distance. CDC has also recently developed this sample signage, which is available on our website. Contact precautions is the type of existing transmission-based precaution that has been used for MDROs. However, as I mentioned earlier, contact precautions has been applied inconsistently for a variety of reasons across nursing homes. As a part of contact precautions, hand hygiene should be performed and gown and gloves should be donned before room entry and then removed with hand hygiene performed before room exit or providing care to another resident. The resident should have dedicated equipment, and ideally, the resident has a private room and is restricted to the room and does not participate in group activities. Applying contact precautions, as I've just described, in nursing homes can be very complex and is made even more complicated and confusing for MDROs based on how we've defined and described transmission-based precautions. So this language is pulled from the current CMS State Operations Manual or Interpretive Guidance for Long-Term Care, which has then been taken from CDC guidelines, and describes that transmission-based precautions must be used when a resident develops signs and symptoms of a transmissible infection. But as we have described, individuals colonized with MDROs are asymptomatic and do not have the signs and symptoms seen during infection. The interpretive guidance then goes on to advise that facilities must identify the type and duration of transmission-based precautions, and that those precautions should be the least restrictive for the least amount of time. But the duration of MDRO colonization in nursing home residents often lasts for many months and sometimes longer. The language then goes on to further specify that when a resident is no longer at risk for transmitting infections, transmission-based precautions should be removed. But we know that residents remain at risk for transmitting MDROs even if they are not actively infected. So focusing only on residents with active infection fails to address the continued risk of transmission from residents with MDRO colonization, which can persist for long periods of time and result in the silent spread of MDROs. There is also a very real and a very important balance that we need to find between maintaining resident safety, and by resident safety, I'm talking specifically about preventing the spread of infectious pathogens, including MDROs, and resident quality of life, including respecting the home-like environment, the importance of socialization and psychosocial well-being, while maintaining the stigmatization that may come with using PPE and precautions. There's also the physical space challenge of nursing homes often lacking private rooms, and in fact, many nursing homes around the country may have triple or even quad rooms. And then the difficulty in restricting movement, such as for those residents that are able to move about the facility, and the difficulty in moving residents, especially those that have been in their location long-term. We recognized that we needed an approach to preventing the spread of MDROs that is specific to nursing homes and takes into account the unique challenges that are faced in the nursing home setting. This approach must clarify how and when to use PPE and room restriction. So for example, when is it appropriate to place nursing home residents in a strict contact precautions, or as is often termed isolation, for an MDRO? We also needed a balanced approach to managing prolonged colonization of MDROs that respects resident rights and dignity and prioritizes resident quality of life. And we must also consider the burden of MDROs in nursing homes, which is often unknown or not fully recognized, and then develop a realistic and feasible approach to preventing the acquisition of MDROs by nursing home residents at highest risk. And so with this in mind, we have developed new guidance for nursing homes focused on the implementation of PPE to prevent the spread of novel or targeted multidrug-resistant organisms. And in this guidance, we introduce and define Enhanced Barrier Precautions, or EBP, and have tried to be as specific as possible about when EBP versus contact precautions is appropriate, as well as specific guidance on implementation. Enhanced Barrier Precautions expand the use of PPE beyond situations in which exposure to blood and body fluids is anticipated. and it refers to the use of gown and gloves during high-contact resident care activities that provide opportunities for transfer of MDROs to staff hands and clothing. These high-contact resident care activities include dressing, bathing or showering, transferring, and providing hygiene such as brushing teeth and combing hair, activities that are often bundled into morning or evening care and typically are happening within a resident room. High-contact activities also include changing linens, assisting with toileting, device care or use of devices such as central lines, urinary catheter, feeding tube, tracheostomy or ventilators, and wound care. These high-contact resident care activities are informed by nursing home-specific research, assessing which resident care activities were the highest risk of transmitting resistant pathogens from colonized residents to the gloves and gown of healthcare providers, which had served as a proxy for hands and clothing. For MRSA, the highest risk activities for transmission included dressing, transferring, providing hygiene, changing linens, and toileting. Similarly, for antibiotic-resistant gram-negative bacteria, the highest risk activities included toileting and hygiene, but also showering and wound dressing changes. The risk of transmission was much lower for activities such as passing medications and blood glucose monitoring. And so for activities such as these, PPE would not be required as a part of enhanced barrier precautions. However, standard precautions always applies. So for potential exposure to blood or body fluids, such as during blood glucose monitoring, PPE would still be appropriate. Enhanced barrier precautions should be used in all nursing home residents with a novel or targeted MDR-O. And currently, those are defined as pan-resistant organisms, carbapenemase-producing organisms, including Enterobacteriaceae, Pseudomonas species, Acinetobacter baumannii, and Candida auris. EBP should also be used in all residents with wounds and or indwelling medical devices regardless of MDR-O colonization status who are residing in at-risk areas. And for most nursing homes, that at-risk area would be the same unit or the same wing that the MDR-O colonized resident is residing on. However, depending on the public health investigation, infection prevention assessment findings, or things like movements of residents, staff, or shared medical equipment, that at-risk area may potentially change. So for an example, if there is an MDR-O colonized resident on one unit, but it's determined during the investigation that residents on a second neighboring unit are also potentially at risk, that at-risk area may more appropriately apply to both of those units. And so in this situation, you would then identify all residents with wounds and or indwelling medical devices residing on either of those units and apply enhanced barrier precautions, or gowns and gloves, for those high-contact resident care activities to those identified residents. Given the challenges that have arisen with using contact precautions in nursing homes for MDR-Os, this new guidance specifies when using contact precautions is appropriate. For residents infected or colonized with novel or targeted MDR-Os, the only situations for which contact precautions are required are for residents with acute diarrhea, draining wounds, or other sites of secretions or excretions that are unable to be kept covered or contained, or during an outbreak where transmission is documented or suspected. For other infections or conditions, such as C. difficile, norovirus, and scabies, contact precautions continues to be recommended as per the CDC isolation guidance and specified in Appendix A. There is no change to the use of contact precautions for these conditions. So why was the EBP guidance needed for containment? The current EBP guidance is focused on MDR-O containment because of our experience in needing a way to help facilities manage additional residents detected as having an MDR-O during screening performed as a part of the public health investigation. Enhanced barrier precautions allows for an approach that is more specific than standard precautions, but is less restrictive than contact precautions, and it's able to be sustained for a prolonged period of time. EBP also addresses the care of residents that are at highest risk of acquiring novel or targeted MDROs. So in terms of PPE and precautions, EBP fits on the spectrum in between standard precautions, where you must make that decision about whether or not PPE is indicated based on potential risk of exposure, and contact precautions, where PPE is worn for all, upon room entry for all activities. Enhanced barrier precautions specifically requires PPE for those high-contact, high-touch resident activities. Our guidance also includes a description of standard precautions as a reminder that standard precautions applies to all residents at all times, regardless of whether or not enhanced barrier precautions or contact precautions is being used. And the PPE required depends on anticipated exposure. Now, pulling the details directly from the new guidance, but comparing enhanced barrier precautions side by side with contact precautions to help visualize some of the similarities and differences. Enhanced barrier precautions should be used for all residents with infection or colonization with a novel or targeted MDRO when contact precautions do not apply. So contact precautions for those MDRO infected or colonized residents would only apply if that resident had acute diarrhea, draining wounds, or other sites of secretions or excretions that are unable to be kept covered or contained. Once that acute diarrhea or drainage has improved, that resident would be able to be on enhanced barrier precautions. Contact precautions is also indicated on a unit or in a facility when ongoing transmission is documented or suspected. So going back to enhanced barrier precautions, enhanced barrier precautions also applies to residents with wounds or indwelling medical devices regardless of their MDRO colonization status, who reside in that same area as the index resident with MDRO colonization or infection. And we are also encouraging facilities to consider applying enhanced barrier precautions more broadly, which may include applying these precautions to residents infected or colonized with other epidemiologically important MDROs, and or to residents with wounds or indwelling medical devices throughout larger areas of the facility. PPE is used for enhanced barrier precautions during these high-contact resident care activities that we've already discussed, that are often bundled into morning or evening care, and that include toileting, device care, and wound care. And for contact precautions, PPE should be used for any room entry and for all resident activities. The same PPE, gloves and gowns, are used for both enhanced barrier precautions and for contact precautions. But another very important distinction with EBP is that a single-person room is not required, and that residents should not be restricted to their room or from participating in group activities. Residents in contact precautions should be considered for a single-person room or for cohorting if available, and should be restricted to their room except for medically necessary care. So based on our observations in facilities throughout the country, we've included recommendations for implementation of enhanced barrier precautions as a part of the guidance, and these also apply to contact precautions. It's very important that signage is displayed clearly outside of the resident room. A stop sign only saying to see the nurse, which is what we have commonly observed in nursing homes, is not enough, as it does not communicate the following important information. The sign should indicate the type of precautions and the required PPE. And for enhanced barrier precautions, the sign should list the high-contact resident care activities as a reminder to staff. Personal protective equipment should be available immediately outside of the resident room for all residents on enhanced barrier precautions, or really any form of transmission-based precautions, including contact precautions, with a plan in place to restock so that supplies do not run out. Because PPE may be necessary as a part of standard precautions as well, PPE should ideally be available at an easily accessible location for all residents. And a trash can located near the door is also helpful for staff to discard PPE before exiting the room. ensure that staff have easy access to alcohol-based hand rub, ideally both inside and outside of every resident room and in other locations where care is provided. Alcohol-based hand rub is preferred over soap and water unless hands are visibly soiled or for C. difficile and norovirus when an outbreak is occurring. And increasing access to alcohol-based hand rubs has been shown to help increase adherence to hand hygiene in nursing homes more than education, so make it easy for staff to perform hand hygiene. Ensuring access to cleaning supplies, such as wipes, is also important in order to promote cleaning of shared medical equipment after use with a resident. And for contact precautions, equipment should ideally be dedicated to the resident. In these pictures, you see some of the methods that facilities have used to encourage staff to use wipes for shared medical equipment and for the appropriate contact time, and for clearly dedicating equipment to residents on contact precautions. Incorporating periodic monitoring and assessment of adherence for hand hygiene, for PPE use, and for environmental cleaning can help with providing individual feedback to staff members, but also with assessing the need for continuing training and education. Moving forward, we are working on developing additional resources to promote enhanced barrier precautions, such as FAQs, and collaborating with nursing home organizations to evaluate staff education and training, quantify PPE utilization, and develop other resources for successful implementation, including educational materials for residents and families. These assessments will include acceptability and feasibility by staff, as well as costs. CDC is also currently funding projects to evaluate a broad range of strategies to prevent MDR-O transmission in nursing homes, including the efficacy of targeted glove and gown use, the role of chlorhexidine bathing in decolonization, and the impact of improved environmental cleaning and disinfection. We are also working towards establishing a working group to convene partners from nursing homes, as well as the academic and public health sectors, to discuss broader implementation of enhanced barrier precautions outside of public health containment. You can find many additional resources on the CDC webpage about containing novel MDROs, Candida auris, connecting with your state public health experts, and a link to the new Enhanced Barrier Precautions guidance. And we want to thank you very much for your time and your interest in combating the spread of MDROs. We look forward to any comments or questions that you may have.
Thank you so much, Dr. Stone and Dr. Jacobs, for providing our webinar participants with such important information about preventing the spread of novel or targeted multi-drug-resistant organisms in nursing homes through enhanced barrier precautions. We appreciate your time and value your clinical insights. We will now go into our Q&A session. Please remember you may submit questions through the webinar system by clicking the Q&A button at the bottom of your screen and then typing your question. Again, please do not ask a question using the chat button. Our first question states, why is CDC only focusing on gown and glove use with enhanced barrier precautions and not other important infection control measures such as environmental cleaning for preventing MDR-O transmission in nursing homes?
This is Kara. So while this guidance does focus on enhanced barrier precautions, preventing the prevention of MDR-O transmission in nursing homes requires much more than just proper use of PPE. Adherence to other recommended infection prevention practices, including performing hand hygiene, cleaning and disinfection of environmental surfaces and resident care equipment, proper handling of indwelling medical devices, and care of wounds is critical. CDC and health departments continue to identify gaps in recommended infection prevention practices as a part of on-site infection control assessments in nursing homes. And some of those examples include things like lack of access to alcohol-based hand sanitizer in resident rooms and other care areas, lack of access to EPA-registered disinfectants at the point of use, and failure to clean and disinfect shared resident equipment after each use. I also want to add that during containment responses, facilities are provided guidance and support to improving all aspects of their other infection prevention practices in addition to implementing EBP.
Thank you very much. Our next question asks, if a resident infected or colonized with a novel or targeted MDR-O meets criteria for contact precautions, do I still need to put other residents on the same unit with indwelling medical devices or wounds or enhanced barrier precautions?
And this is Kara again. The answer is yes. Even if the resident colonized with a novel or targeted MDR-O is placed on contact precautions, enhanced barrier precautions is still recommended for other at-risk residents, those that have indwelling medical devices or wounds in that same unit or ward or area.
Thank you for that. Our next question asks, doesn't posting signs specifying the type of precautions and recommended PPE outside the resident room violate HIPAA and resident dignity?
And this is Kara. No, signs are intended to signal to individuals entering the room that the specific actions that they should be taking to protect themselves and the resident. To do this effectively, the sign needs to contain information about the type of precautions and the recommended PPE to be worn when caring for the resident. Generic signs that instruct individuals to speak to the nurse are not adequate to ensure that precautions are followed. And we've often seen that speaking to the nurse may not happen. So signs should not include information about the resident's diagnosis or the reason for precaution because that is information that would violate HIPAA and resident dignity. And as we have shown on one of the slides in the presentation, CDC has created examples of signs that can be used by facilities to communicate information about transmission-based precautions and enhanced barrier precautions. And facilities can use these signs or modify them to create signs that work for them.
Thank you. Our next question asks, do we have any idea when the CMS State Operations Manual will be released and if it will reference enhanced barrier, enhanced standard precautions?
So this is Namali. It's a very good question. We have been talking with our colleagues at the Centers for Medicare and Medicaid Services, or CMS, about enhanced barrier precautions and our guidance and for use of more PPE, especially framed around the containment of emerging antibiotic-resistant organisms throughout the development of the guidance and as a part of the release. And so they're aware that there are going to be more facilities working with public health partners in this containment response, incorporating gown and glove use as part of resident care in a bigger way. Given how new the guidance is and that it is framed around containment, it may not be something that they choose to incorporate into the surveyor guidance that's going to be released. However, to be honest, we really can't say.
Thank you for that. Our next question asks, why would someone on contact precautions not be advised to participate in group activities?
So people are placed, this is Damali again, people are placed into contact precautions when they have a communicable pathogen with a lot of risk for transmission into the environment and contamination into the environment. And for the window of time when that kind of risk of spread is greatest, that is when we recommend that those individuals with those clinical syndromes or infections are not involved in group activities. However, as soon as the issue, whether it is acute diarrhea or challenges containing secretions, as soon as those issues have resolved, then contact precautions can be transitioned to something like enhanced barrier precautions. It's really containing people during the highest risk point in a communicable infectious disease.
Thank you. Our next question states, how long should a resident remain on enhanced barrier precautions?
So so the way that enhanced barrier precautions has been intended to be applied, and this is Kara. But the way that enhanced barrier precautions has intended to be applied is for the duration of that resident's stay at the facility. It is possible if a resident was placed in enhanced barrier precautions due to something like a wound or an indwelling medical device, and that wound has since resolved or the device is no longer in place, then that resident may be able to be taken out of enhanced barrier precautions with standard precautions alone being used.
Thank you. The next question asks, what is the best practice or opportunities to identify colonized residents?
That is a very good question and a difficult one to answer because as we talked about, often the risk factors and the exposures that an individual might come to a facility with that puts them at risk for being colonized with an MDR-O might be things that you're aware of, but their actual status, their MDR-O status, may not be information readily accessible. So one of the benefits of the enhanced barrier approach is the risk-based approach to application of gowns and gloves, where you're not relying on knowing whether somebody is colonized, but you're looking at the potential they have to either already be colonized or to be at high risk for acquisition, and you're using gowns and gloves during their care as a protective measure. In other post-acute care settings, like long-term acute care hospitals, many have employed active surveillance for new admissions, where they're actually obtaining swabs of various body sites like the nose or the axilla and groin, looking for the presence of resistant organisms colonizing those individuals as they're coming into the facility. And that's a strategy that can work, especially when you're caring for a very high-risk population. However, there have to be some decisions about how to offer and build that kind of a process into your workflow if you're going to consider active surveillance screening for new admissions.
Thank you. Our next inquirer asks, as I read the EBP guideline, it states novel or targeted MDROs are defined as and lists 5 categories. This does not include MRSA and VRE as I read it. Is that correct? It is currently proposed for those novel or targeted MDROs?
This is Kara. Yes, that is correct. The current guidance is focused on containment activities and specifically those targeted pathogens. However, we do encourage facilities to consider applying enhanced barrier precautions to other epidemiologically relevant or important organisms at their facility. And we are also considering and investigating the application of enhanced barrier precautions more broadly to other organisms.
Thank you. Our next question states, on the high contact activities slide, should the list also include therapy activities? If not, what precautions should be taken for these residents in therapy?
And this is Kara again. And so that high contact, the slide that includes the high contact resident care activities are focused around activities that have been investigated in nursing home settings that have been specific to activities that are typically performed within the resident room. However, it really depends. For physical therapy, there may be high contact activities. And so it really depends on what is being done during therapy. And therapists should consider the use of gowns and gloves when they are working with residents on enhanced barrier precautions in the therapy gym if they are anticipating that close and prolonged contact when assisting them with things like transfers or mobility. But also, as a part of standard precautions, gloves and gowns may be indicated based on potential exposure, and then they should be removed and hand hygiene should be performed when moving to work with another resident. Therapists should also be ensuring that reusable therapy equipment is cleaned and disinfected after each use, and that surfaces in the therapy gym are receiving regular cleaning and disinfection.
Thank you. Our next inquirer asks, do you discontinue EBP with a negative culture or swab and return to SP, or are EBP ongoing once MDR-O is ID'd?
So this is Namali. The role of rescreening is something that comes up quite often as a question when thinking about use and implementation of precautions, and can we stop these precautions at some point. As Kara mentioned earlier, the way Enhanced Barrier Precautions is being rolled out, it's really meant to be a more sustainable approach to gown and glove use during care because we know that MDR-O carriage can be quite prolonged, especially in individuals who continue to have a lot of functional dependence and high-risk care needs that continue to make them more vulnerable to retaining those organisms. In addition, a challenge with retesting or rescreening to see if carriage has been cleared is that the reliability of those tests is quite variable and often can lack sensitivity, meaning you may get a negative swab result and it turns out, in fact, that individual still remains colonized with that MDR-O. So it is not a practice that we are routinely recommending as a measure to remove somebody from precautions.
Thank you. Our next question asks, if it is difficult to know the colonization status, shouldn't all residents with indwelling devices and wounds have EBP?
So this is Namali. Yes, actually, we 100% agree with that sentiment. And as Kara alluded to, we are exploring ways that enhanced barrier precautions might be applied more broadly in nursing homes outside of an AR containment response. And that is certainly a very pragmatic, forward-thinking approach that we would encourage facilities to consider, even those that may not be aware of a novel or emerging pathogen in their resident population. But if you care for a very high-risk group of residents, that would be a very smart strategy to consider.
Thank you. The next question asks, why are you recommending alcohol-based hand sanitizer instead of hand washing?
Well, since 2002, the CDC hand hygiene guidelines have identified alcohol-based hand rubs as the preferred method for hand disinfection in most clinical situations, except when hands are visibly or grossly soiled, because we have seen many studies demonstrate the improved efficacy of the alcohol-based hand rubs over hand washing when it comes to decontamination of organisms on hands. There are reasons for that include use of alcohol-based products are not as dependent on technique, and with hand washing there has to be quite a lot of attention to getting soap on all of the right surfaces and also for the right duration of time. And if you spend time in healthcare facilities and observe caregivers who are very busy people, they don't have often the same amount of time that they need to be effective with their hand washing technique. So that alone is a major reason why alcohol-based hand products are more effective. In addition, they can be more accessible than sinks. If you think about it, in any building, you may be able to put more dispensers up to make alcohol-based products more available, but it's often hard to replumb or add new piping, so it's harder to make sinks more available. And as Kara mentioned, the increased access to alcohol-based hand dispensers does improve hand hygiene in nursing homes and other healthcare settings.
One of the common questions that we're seeing from our inquirers is, where can they acquire these signs?
So the signs are on our website, and they're actually, the Enhanced Barrier Precautions sign is linked directly to the EBP guidance on our containment website. There is actually a hyperlink to the other transmission-based precautions signs as well, and they're also found on our website for implementing transmission-based precautions in healthcare facilities. We can make sure some of those links are on the Coca-Cola website as well as additional resources. Thanks for the question.
Thank you. Our next question asks, are these new precautions applicable to acute care facilities and LTACs?
So currently, the Enhanced Barrier Precautions guidance is applicable in the nursing home settings. For the other settings, you would continue to follow the CDC isolation guidelines. And this is Kara speaking.
Thank you very much. Our next question asks, when does this go into effect?
And this is Kara. This guidance was published to the CDC website in July of this year and is already in effect, and in fact has been being used as a part of containment responses and work between facilities and CDC and health departments for more than a few months now. So we encourage you to continue to familiarize yourself with it as it is being implemented currently.
Thank you very much. We have time for one more question, and the question states, if we screen the infected or colonized resident and confirm they are no longer colonized with the novel or targeted MDR-O, may we stop using enhanced barrier precautions?
Yeah, so it is, I totally appreciate, this is Namali, I appreciate the desire to be able to remove somebody out of enhanced barrier precautions if you're able to demonstrate through rescreening that they've cleared. And just so people are aware, a single repeat swab is inadequate to determine that somebody has cleared their colonization status. There are some parameters that need to be followed if you're going to even consider doing rescreening, including waiting at least 6 months from the original detection of an organism before you would be eligible to consider rescreening, and also ensuring that they have been off of any antibiotics or therapies for that particular organism or in general prior to doing the repeat screening tests. There have to be at a minimum 2 negative cultures at least 2 weeks apart in order to verify that somebody's status is no longer detectable, and that's because, as I mentioned earlier, there's a poor reliability of a single swab to verifying that somebody's genuinely cleared. When we have followed individuals for prolonged periods of time on the order of months, we find that they can have intermittent negative cultures followed by positive cultures, and that's often when their health status has worsened or they've been re-exposed to antibiotics. So you really have to think about what is the ongoing care and needs of the person that I'm trying to demonstrate that they've cleared their carriage before feeling confident that that negative test will remain negative. The other thing I would say is that if the facility has been using enhanced barrier precautions in the care of this person because of a novel organism, and even if they can no longer detect that organism, the resident continues to have a wound or a medical device that makes them still eligible for EBP because of their ongoing risk for acquisition, then they would be encouraged to retain and keep using enhanced barrier precautions in their care.
Thank you very much. This concludes our Q&A session. We received a tremendous amount of questions today, so if we were not able to get to your question due to time constraints, please note that you can send your questions to coca@cdc.gov and we will share your question with our presenters. We will then share the responses with you via email. On behalf of COCA, I would like to thank everyone for joining us today with a special thank you to our presenters, Dr. Stone and Dr. Jacobs. This webinar will be available to view on demand within the next few days on the COCA website at emergency.cdc.gov/COCA. Again, that web address is emergency.cdc.gov/COCA. All continuing education for COCA calls are issued online through TCE Online, the CDC training and continuing education online system at www.cdc.gov/TCE Online. Those who participated in today's COCA call and would like to receive continuing education should complete the online evaluation by November 25, 2019 and use course code WC2922. Those who will view the webinar on demand and would like to receive continuing education should complete the online evaluation between November 25, 2019 and November 26, 2021 and use course code WD2922. Please join us for our next scheduled COCA call on Tuesday, December 10 at 2 p.m. Eastern, where the topic will be updated guidance for using intravenous artesunate for treating severe malaria in the United States. To receive information on upcoming COCA calls or other COCA products and services, join the COCA mailing list by visiting the COCA webpage at emergency.cdc.gov/COCA and click on the Join the COCA mailing list. To stay connected to the latest news from COCA, be sure to like and follow us on Facebook at facebook.com/CDC Clinician Outreach and Communication Activity. Again, thank you for joining us for today's webinar. Enjoy the rest of your day.